Okay.
All right. Well, good morning, all. You see the management of bloodborne pathogens slide?
Yep.
Good, okay. So what we want to talk about is management of bloodborne pathogens. We've had some questions arise recently that lead me to recognize that it's something we need to talk about from time to time and discuss the evaluation and management of folks that come to us with bloodborne pathogen exposure. So we had a patient that was seen in one of the clinics a couple of months ago, just really kind of typical in many ways. An employee, a 53-year-old female on 10/19/21. And you see that slide, do you, clinical course?
Yes.
But inadvertently stuck her left hand with a needle following administration of influenza vaccine. She comes to DOD for management of bloodborne pathogen exposure. So here's a little bit of the story, and I'm interested in your response, what you observe in these 3 bullet points. Source patient was contacted regarding vaccine status, and the patient would bring that information, the source patient would bring that information on return for the 6-week check. No other source patient information was available in the medical record or in any other source. So it was going to have to come from directly from the source patient. And then source patient information never became available for whatever reason. By 12/6/61, 6-week visit, the exposed patient remained asymptomatic. Lab testing revealed HIV, non-reactive, hepatitis B surface antibody reactive, hepatitis C antibody non-reactive. What is there anything that catches your attention among those 3 bullet points that catches your attention?
Well, the hepatitis B surface antibody, looks like he's been vaccinated.
Probably so, maybe the disease, but in most cases, especially with healthcare workers, reactive. So we needn't worry about hepatitis B going forward. How about bullet point 1? Anything in that catches your attention? Well, here's the answer. 6-week check to get the source information. We'll talk about along the way here, PEP for HIV really needs to be started in the first 72 hours and ideally in the first 2 or 3 hours. So getting the source patient information at the 6-week check really, it has some value, but not much in terms of making the decision about PEP, which is the most important piece of that. So we would ask the patient wherever they're going to get that from the source. We need it much sooner than 6 weeks. So having established that this occurred, then the question is, we need to make some decisions about exposure risk. The assumption, the presumption, kind of the starting point will be, if there's a needle stick, we're going to offer PEP. That's the starting point. And then we go from there and go through the process of deciding if that's really necessary and or does the patient really want it. So we make the assumption we're going to give it, but we're going to consider factors to decide if that's really necessary. And so one of those is, what's really the fluid exposure risk? Well, there are infectious fluids we recognize: blood, semen, vaginal secretions, other contaminated fluids, that is contaminated with visible blood. Those are all exposure risks. There are some with which we're not really likely to come in contact: cerebrospinal fluid, pleural fluid, peritoneal, pericardial, and amniotic. Those of course, when I say we're not, what I mean is healthcare workers in the clinic setting, which is where most of these patients are exposed, are unlikely to be exposed to one of those fluids. On the other hand, if they're in the hospital, in the ER, then those are possibilities. And then there are non-infectious fluids: feces, nasal secretions, saliva, gastric secretions, namely vomit, sputum, sweat, tears, and urine. And where I think this is significant and useful is, and where I have seen this in the past working with the prisons, is prisoners collecting urine and then throwing it on. Seville, can you mute it? Need to mute your phone.
Okay,
Uh,
I'm ready to go.
Everybody needs to mute Seville. Seville, mute the phone. So in any
Okay,
case-
I'm working on it.
Okay, thank you. So urine in the prison being splashed on the guards, nobody wants to see that, but that's not a contagious fluid. So are telling, of course, the guard that may not reassure them, but nevertheless, it's not a fluid of risk. So if that's one of the considerations, then that's going to diminish our the likelihood of our recommending PEP. So what's the risk assessment? Well, there are a couple of things to recognize, particularly related to HEV. It only survives a few hours generally outside the body and is diminished or varies with diminished viral load, heat, humidity, sunlight, and variation in acidity above or below 7.0. And so particularly syringes that look like they've been outdoors for a period of time in the heat, the likelihood of there being residual viable HIV virus is very low there. And so generally the recommendation is in situations where folks are coming across needles, and these are folks working around dumpsters or other places, then the risk is really pretty low of HIV. Hepatitis B outside the body can survive up to a week, and Hep C, depending upon circumstances, up to 6 weeks. And then what's another risk assessment consideration? What among the odds of transmission? Well, the source blood status, that's an important potentially risky fluid. But then blood draw versus injection, in a situation where blood's being drawn, removed from the body, and the source patient's blood is in the needle, then that's riskier than giving an injection, which is what we not infrequently see, giving a flu shot, giving influenza. The only blood potentially to expose the exposed patient would be on the outside the needle. So the risk there of needles that are used for injection rather than blood draw are much less. The deeper the needle injury into the exposed patient, needle with visible blood for sure, needle with source blood, needle that penetrated source blood vessel, in other words, into a vein rather than just into muscle tissue or fat, as well as the source patient that has a terminal illness. Those are all considerations in deciding what the risk of transmission really is. And then what's the management that needs to be applied? Well, wound cleansing, we know alcohol is virucidal for HIV, Hep B, and Hep C, other antiseptics. So those should be used at the exposed patient's wound site, puncture site. But we don't really know, although we know that alcohol is virucidal, we don't really know what the effectiveness of that is in preventing HIV. So best to wipe off the wound, but that may or may not have an impact. So then we get to the point of making decisions about what's to happen with the patient regarding hepatitis potential exposure to HIV, to Hep B and Hep C. Well, the initial testing for when we're considering HIV is going to be testing for IgM, IgG antibodies, and HIV P24 antigen. And I think most of us are doing 4th generation testing now, which includes the antigen. And so that's what's going to come with that test. So we want to be doing that. And if source testing is done at the exposure site, in other words, and this happens sometimes, there will be an exposure in a clinic, family practice or other clinic, the provider there will know, or the exposed staff will know to try and get source testing. Hopefully they've done 4th generation testing, but maybe not, maybe it's 3rd generation testing. So actually we'd like to know that if possible. And then the exposed patient, we're generally doing 4th generation testing. So we would expect to get results back of IgM, IgG, and HIV P24 antigen. So the initial testing for the source, if we have that patient, sometimes what will happen is that the site where the puncture occurred will send the source patient over. We've had that particularly happen coming from Vantage Eye across the street. So they see what happened and they'll send the patient over and we'll do the testing. And so we're going to want to be doing the 4th generation testing on them. And then if the determination is eventually made, the best treatment is Truvada once a day for 30 days. What monitoring do we do for HIV exposure? Well, we're doing for disease to the second line there. We test at 3 weeks. Well, I should say for the bottom line's 4th generation, we're going to test at 6 weeks and 4 months for HIV. There's a somewhat different schedule if 3rd generation testing is being done, which is 6 weeks, 3 months, and 6 months. And we've got in a couple more slides, a summary slide that'll show that. If we're giving PEP, then you'd like to do CBC and CMP, metabolic panel at 2 weeks and 4 weeks as well. And that's because of the potential adverse effects of Truvada. Now for hepatitis B, the initial testing, hepatitis for the source, hepatitis B surface antigen, hepatitis B surface antibody, and we're particularly interested in antigen. And then for the exposed, the same testing, hepatitis B surface antigen and antibody. And what we would expect there, of course, if there's a risk from the source that that antigen is positive or negative, and the antibody is a little bit less useful from the exposed standpoint, that would be too early to see in the exposed patient from this incident to see positive hepatitis B surface antigen. And so it's really antibodies we're looking at to see if they're protected. Hepatitis B, what management. And so if the source patient is hepatitis B surface antigen negative and or the exposed patient is hepatitis B surface antibody positive, no further treatment. So in the example we just had, that person's hepatitis B surface antibody was positive, they're immune, and so we don't need to worry about hepatitis B beyond that. If the source patient is positive or unknown, and the exposed patient is vaccine non-responder or unvaccinated, then we're going to give HBIG, hepatitis B immune globulin, 2 shots a month apart and start the hepatitis B immunization. If the source patient is positive or unknown and the exposed patient had unknown vaccine response, in other words, they've gone through the 3-shot series and the response is unknown, then ideally we would give 1 dose of HBIG and 1 dose of hepatitis B vaccine, those in 2 different body locations. I don't know if we're keeping HBIG in the clinics or not. I would suspect we're probably not. Scott, do you know, do any?
We do not.
Yeah.
So, if we make the decision, we have to send them to the ER, Steve.
Right. So I think the likelihood of using that is so low, it's not, I don't know what the shelf life is, not worth keeping. And then monitoring hepatitis B surface antibody at 6 weeks and 6 months for hepatitis B. And an interesting graph, I just put this up to indicate at various points when the hepatitis B surface antigen is positive and then wanes, and when hepatitis B surface antibody is positive and persists. And there's a period of time, there's this very narrow window between the acute infection phase and the early recovery phase where hepatitis B surface antigen is low and hepatitis B surface antibody has not is just beginning to arise. And so it's possible that during that time there could be a problem and we wouldn't recognize it. A thought is, and some recommend hepatitis B core antibodies, you see, are rising much sooner. And some advocate for testing for hepatitis B core antibodies, but that's not in the protocols that I've found. Management for Hep C, the source, you want to be testing for, if possible, Hep C virus RNA, of course, the antigen or the RNA, and if not available, then Hep C antibody. And then the exposed patient initially, Hep C antibody, and if the source is positive, then test for Hep C viral RNA. And if the RNA is negative, then no further testing. And then we monitor the Hep C viral RNA at 6 weeks, initially, and then at 6 weeks, and then at 6 months, Hep C antibody, and if positive, reflex hepatitis B, hepatitis viral RNA at 6 months. Now that appears on this sheet. And I recommend that everybody prints this and keeps it in the clinic, and it makes it, I think, really easy, unless somebody has a better solution, to know what to do when we see these patients when they come in. What support sources are available? I found, and I've talked to maybe 6 or 8 or more times, National Clinicians Post-Exposure Prophylaxis Hotline. It's up in San Francisco, and they are very helpful. Somebody gets right on the phone, they give you good, sensible information, recommendations as to what to do. And it's, of course, primarily in regard to HIV, but helping you to determine those patients who really don't need PEP. So I really recommend, if you don't have this handy in the clinic, that you keep this resource available and call them if you have any particular questions.
Steve?
Yes.
What kind of key pieces of information do you need to have handy when you call them?
Well, you would like to know when it occurred. You would like to know what the nature of the exposure was. In other words, was it where you administering a fluid, or was the exposed person administering a fluid or removing fluid, a blood draw? Would like to know, if possible, of course, the source information, although if we know that, we may not need to call the hotline. But, and then the health, any information they have about the source patient and health of the exposed patient. But it's mostly, when did this occur? What was the nature of the exposure? Was there blood visible on the skin, on the needle, or those places primarily? So, and they'll ask you the questions of information that they need to have, and it's really good. I've only called them Monday through Friday, but they're apparently open 7 days a week, and so if it's UCSF. So keep this number handy if you don't already have it out, and keep that little summary sheet of timing and treatment and exposure, monitoring handy. And anybody have any questions about that? Anybody doing any of this differently than what I've described? Anybody have any suggestions for how they've been particularly successful in managing these things? Actually, let me comment on one other thing. Talking to patients about this, what I do is I explain much of what we've gone over, talk to them about the exposure risk, share that information, indicate what my sense of their degree of risk is. If I've talked to the hotline, I give them that information. And then I ask them what they would like to do. I talk to them a little bit about Truvada, some of the side effects. And and ask them what they would like to do. And I've gotten a range of folks. I've had some that want 100% protection no matter what. They're willing to take the Truvada, some of the nausea that can occur, and they want treatment. They want prevention, PEP. And so I prescribe that. I've got others that really just don't want to do anything after the conversation, or even came in feeling they don't have a problem, and so they don't. And others, we just kind of talk back and forth. If I'm in doubt, if there's a question, then I would encourage them to take PEP. But for those where I think the risk, after my consideration of the situation and maybe talking to the hotline, if I think the risk is really minimal, then I'll indicate that to them. But in the end, I consider this to be a patient decision, not asking them to make a medical decision, but I ask them to help me help them in making the best decision about what to do. Anybody had that discussion with folks? We don't see a lot of this, but we see it enough that we need to have this plan, or a plan for it. Anybody had this kind of discussion in the last couple of months, or had any questions about it?
Dr. Schumann, I have a question.
Yes, Danny.
One is regarding the Hep B immune globulin. Is, from what I remember, it may have changed. Do we still have a week to administer that? So usually you can then get if the patient is, or the exposed patient is unsure of their hepatitis status, we still have time to get the labs before sending them to the ER.
Yeah, the Hep B, ideally for PEP and HBIG is going to be as soon as possible. Ideally in the first 3 days. You get much beyond that, and then the benefit diminishes. So I would do that. I would make that decision sooner rather than later. If you're just not going to get the source information, I would consider it to be source information, unknown.
Okay, perfect. Thank you. And then one last thing regarding if we decide we wanted to do Truvada, but it's work comp and the patient would have to pay usually out of pocket because it's hard to get covered. I mean, usually authorization that soon. Would you just send them to the ER as well to initiate that?
You mean to get a prescription?
To get it covered and filled at the pharmacy, because if it was work related.
I don't know. Would that make a difference to the pharmacist? We've sent them, I think it was to CVS on South Main. I've forgotten right now, but we've sent them and patients have gotten it. I have to say, I'm not quite sure what happened. We generally send them with the work comp information. We'll give them a copy of the first report and the sheet we get, the information we get from the employer. I guess I would have to check and see what's actually happened in terms of their getting the medicine.
Danny, I can give you my experience. The pharmacies, I think, recognize the immediacy of these prescriptions. And in my experience, they've actually dispensed the medication to the patient the same day that I wrote it for them, without having to wait for authorization.
Oh, okay.
Yeah, I mean, I could, if anybody else has any experience and they've had delays, you can pop up and say something. But I've done this probably 3 times in the last 10 years, and all 3 times the patient got the medication that day.
My most recent patient had to pay out of pocket, I think like $1,500 or something like that. They were going to get reimbursed, but that was the only reason why I asked, because of that. Yeah.
Yeah, I guess the other way to do it is maybe, you could write a prescription for maybe 5 days, so they only have to pay that out of pocket, and then you give them the rest in another prescription. Because usually in 5 days we'll get approval. Well, we can make calls and usually get it authorized. So maybe do it that way.
I've actually, Dr. Pricey, had this come up a couple times between me and other providers, and it seems like in the northern clinics, there's not a pharmacy that will dispense it without charging them exorbitant amounts. And I've had 2 people actually miss out completely on being able to do it because of that. So the only way that we've found we can actually get the patient started right away on it is to send them to the ER, because they actually dispense it in the ER. They've got like several days on hand, and so they give it to them while the workman's comp figures things out to get the rest of it to them.
That's really great to know. Thank you for
Yes,
letting
yes.
me know.
That's, and actually one of the challenges I found as much in the past is not all pharmacies keep Truvada. And so it's a matter of knowing, it might be worth calling around, being certain that each clinic knows which pharmacy has it and what their policy is. And for those that just aren't going to give it out without authorization, then I think the ER is the place for them to go.
That's a good idea.
Any other questions? I'm
I
sorry.
have a question.
Yes.
So in other places that I have worked, we have had a sheet that lists the percentage chance, or the chance percentage of somebody getting HIV from a needle stick, and then all of the side effects listed on a form that we can actually give the patient that they can read and digest, versus listening to us say this and then trying to make a decision based on what somebody is saying, versus having a minute to read it, sit there, digest it. Is there any way we can get a form like that to hand to our patients? They seem to be pretty effective.
Yeah, that, I can put that together. That's an interesting idea, and I think that's a good idea. And
On this form, it would say that your chances of getting HIV from a needle stick are less than 0.3%.
right.
I assume that's accurate. I don't know. I
Yes.
never investigated it, but that's what the form indicated.
Yes. That is a correct figure, and I've seen that in several places before. That's 3 in 1,000. Actually, it's less than 3 in 1,000, and that's 3 in 1,000. They've studies that have been based upon source patients that are known to be have active HIV and needle sticks in a staff person, and the incidence of conversion is less than 3 in 1,000. So it's very low. And I usually tell patients that figure. But I say at the same time, if you're 1 of 3, that's not good. But it is,
Right.
the likelihood is very low. And that's one of the risk factors in the risk assessment you make of deciding whether or not to give HIV, prophylaxis is, what's the real risk to the patient? But I like the idea of actually handing them something. And while you're going about other things in the clinic, give them a few minutes to reflect on that.
Right. I've been very successful with that method in other locations. And I think I've had when I worked in the ER, I had this conversation multiple times with patients, and I've had very few people choose to take the PEP pack after they've sat and read that, and then read all the side effects of the medication. It just seemed to be a good process.
Yes, that's a great idea. In fact, what I will do is put that together, and then I'll email out to everybody the sheet that you're looking at now. That's the summary. So you can, and then the source, the information, this sheet. Hopefully you can keep that handy in the clinic. And then I think going about making or figuring out where to send them for PEP, that's each clinic needs to determine if there's a pharmacy nearby that will fill a prescription and wait for confirmation for work comp to come later or not, and consider sending them to the ER if such a pharmacy is not available. Any other questions? Let me stop the stop the recording.